The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. My name is Hunter Lyles, and I'm a paralegal at Lyles Parker. Thank you for joining us today for our monthly Wednesday webinar series, which is presented by Lyles Parker and sponsored by the Texas Association for Home Care and Hospice. Today's topic is value-based purchasing and alternative payment methodologies. Where does your home health agency or hospice fit into delivery system reform? Value-based payments and alternative payment methodologies are becoming more prevalent in both the public programs and private insurance. Additionally, the HHS has recently published new safe harbors that directly affect these payment mechanisms. This session will discuss some of the various VBPs and APMs that affect home health agencies and hospices, the new safe harbors related to these payment mechanisms, and how you can participate, and the pitfalls of which you must be aware. And with that being said, I'll pass it on to our presenters, Michael Cook and Heidi Kocher.
Good afternoon. As Hunter has mentioned, my name is Michael Cook, and I'm a partner and co-chair in the Washington, D.C. office of the law firm of Lyles Parker. I've been representing healthcare-related clients full-time for almost 40 years, and before that, at the start of my career, I represented the federal regulators of the Medicare and Medicaid programs as an attorney for the United States Department of Health and Human Services. During this period, I've represented virtually every segment of the healthcare industry with a strong emphasis on subacute providers such as home health, home care, and hospice, on regulatory compliance and investigations, business and policy issues, frequently before state and federal regulators. I'm also a fellow of the American Health Law Association and the chair of the board that oversees Virginia's Medicaid program as an appointee of Governors McAuliffe and Northam. And I've advised on healthcare issue on political campaigns for state and federal campaigns, including presidential campaigns. I've also served on the healthcare transition teams for 3 of Virginia's governors-elect. Heidi, do you want to introduce yourself, if you would?
Hi, sorry. All of a sudden, a little bit of frog in my throat. My name is Heidi Kocher. I'm also a partner with Lyles Parker. I've been doing healthcare law for about 25 years. I have spent my entire working life in the healthcare field in one form or fashion or another. My expertise is in compliance and regulatory work, structuring transactions, making sure that folks have a correct compliance program, and so on. I've represented providers large and small, from very large hospital systems down to single practitioner practices and offices. And I'm so happy to be able to partner with Michael to discuss value-based payments. Michael, you want to go ahead?
Sure. Hunter, can you move to slide 3 if you would? Next slide. Thanks, Hunter. First of all, it's a pleasure to present to you on this topic today. It's of great interest now, but it's going to become even more so, I assure you, in the future. And it's going to be namely how we're changing our payment systems, how we deliver healthcare, and basically where you fit in. I'm going to begin the presentation by briefly discussing how we got here and why alternative payment methodologies are almost certainly going to be the wave of the future. We're then going to discuss several of the value-based purchasing and alternative payment methodologies that drive delivery system reform and that most directly affect home health and agencies and hospice. Because of the great number of these programs, we've chosen 4 that provide both a variety of the types of programs that are out there, and just as importantly, are likely to serve as models for what we're going to see in the future. Heidi's going to begin by discussing the value-based demonstration model for home health that previously was piloted in several states, of which Texas wasn't one, but that now will be nationwide and will affect home health agencies in Texas as well. I'll then discuss the Comprehensive Joint Replacement Program, which is the first mandatory pilot that is a disease-specific bundling program, something we think you're going to see more of in the future. Heidi will then discuss the Medicare Shared Savings Program that is based on accountable care organizations, again, something that's going to become more prevalent in the future. And I'll then play cleanup with the most advanced pilot, namely the global and professional direct contracting model. And as I said, we've chosen these because, one, they provide a variety of types of models out there, and two, we think they're going to be serving as what you're going to see in the future. And finally, although we're not going to have time to discuss them today, we've included slides to serve as a resource for two other programs: the bundled payment, the BPCI pilot program, bundled payment care initiative that's now ended, and the new flexibility provided to Medicare Advantage plans to cover as supplemental benefits such services as home or personal care. And you can feel free to call either of us if you've got questions on those programs. All right, Hunter, can we move to the next slide if we could? All right, so how did we get here? As I'm sure many of you know, the U.S. has by far the highest spending rate on healthcare as a percentage of gross domestic product in the world. To give you a practical understanding of the magnitude of the issue, prior to COVID and in the future, the U.S. spends up to 18 to 19% of GDP on healthcare, while Switzerland, the second highest, spends about 12%. So there's been a tremendous emphasis under the Affordable Care Act in piloting payment methodologies to incentivize delivery system changes that reduce costs while improving quality. And as part of the ACA, Congress established the Center for Medicare and Medicaid Innovation, or CMMI, which was provided $10 billion to fund pilot programs. And most importantly, the Secretary of Health and Human Services was given the extraordinary power to expand the pilots regionally or nationally without going back to Congress, if the CMS actuary determined that they either improved quality without increasing costs, reduced cost without reducing quality, or both. And currently, CMMI has implemented more than 90 pilots throughout the country. And CMS also has implemented programs such as the Medicare Shared Savings Program through ACOs, accountable care organizations, value-based purchasing for certain types of providers, and what we call the MIPS program for paying for physician services. And Liz Fowler, who's the new director of the Innovation Center, recently indicated that there would be fewer and more targeted pilots in the future. And the new CMS administrator has indicated that we're likely to see more mandatory alternative payment methodologies and pilots in the future, as opposed to those that are voluntary in nature. And the fact that we're going to be seeing an accelerated emphasis on value-based payments is demonstrated by the fact that the Office of Inspector General and CMS recently published new and revised safe harbors and exceptions to the anti-kickback and Stark laws to accommodate value-based purchasing and bring these exceptions up to date to accommodate VBP. My partner Robert Lyles and I did a session for TAC on the new safe harbors in May of this year, and the slides are available, I believe, on our website and certainly through TAC. And Heidi and I will be working with TAC to hopefully fit in a session on the new Stark exceptions in the near future. Hunter, can you go to the next slide if you would? This slide, which comes from a CMS website, just shows just some of the value-based purchasing and alternative payment models that CMS has developed and tested to achieve the objectives of quality care at a lower price. And this slide also just gives an indication of how these various quality improvement and payment reform programs relate to other CMS initiatives. Hunter, can we go to the next slide if we could? Heidi, do you want to talk a bit about this?
Sure. As Michael said, because of the directions that these changes are all taking, the CMS and OIG realized that the Stark and anti-kickback statute needed some updating to accommodate value-based payment. Most recently, CMS published 3 new exceptions under Stark, saying that remuneration provided to value-based arrangements is not a problem, is not prohibited, in order to, again, protect these financial arrangements between the participants in a value-based enterprise. And you'll see this acronym a lot in the future, VBE, and it's a value-based enterprise. So the first one is a full financial risk exception, where basically if everybody is financially at risk for not just savings, but also losses, there is an exception for that. There's one for a physician at meaningful risk. And there is also another exception for value-based arrangements where there is no risk. So this is related to when I talk about the ACOs, the one-sided risk model where the participants share in savings but not in risk. Again, one of the key things about these things, especially on the Stark updates, is that these new exceptions apply regardless of whether the compensation arrangement relates to care furnished to a Medicare beneficiary, a non-Medicare beneficiary, or a combination. This is a key change because heretofore Stark applied only to federally funded programs. One of the updates now, again, I cannot emphasize this enough, is that these exceptions apply to all payment methods. So if you're only dealing with private payers, you now particularly need to be concerned about Stark updates. As with all of these exceptions, there are specific criteria and definitions. It's beyond the scope of this presentation to go into that. Look for a future presentation on this for more details and more in-depth discussion. Next slide, please.
Yeah. Hunter, you want to put the, yeah. This
Also,
this slide again.
I'm getting just a question from someone in the audience saying they tried to open the handouts, but it appears they're the ones from the June 2nd ADR's prepayment reviews. Are these by any chance the similar handouts that you're using for today, or no?
No.
Okay,
no.
So I will send those out to all the participants then.
Yeah, that's fine. That's fine, Hunter.
Okay.
This particular slide simply lists some of the new safe harbors, again, from the to the anti-kickback statute. We did as I said, my partner Robert Lyles and I did a full presentation recently for TAC on this. The slides are available, I believe, on our website or through TAC. If they aren't, feel free to email Robert or me. Because we have such limited time and so much information, I'm simply going to be skipping over this for now. Understand that the purpose of these is to make it easier and to protect, if you meet each criteria, these value-based enterprises in the future. Some of them are corollaries to the new Stark exceptions, although they are not necessarily identical for reasons that we'll go into on the Stark, hopefully the future Stark presentation. But you have to meet each element for it to apply. Heidi, do you want to take over and talk a little bit about the Home Health Agency value-based purchasing?
Sure. Hunter, if we could move to the next slide, please. So there was a new proposed rule published for the calendar year 2022 earlier in spring. And among all the other things that it had in that, I'm not going to go into the whole detail of it, but I want to focus specifically on the value-based purchasing aspect of it. So this proposed rule has indicated that home health value-based purchasing model, which I'll talk about next, is going to be expanded to nationwide. So the demonstration project was 9 states, and now it is going to expand nationwide starting January 1st, 2022. Because of this nationwide expansion, they're going to end the demo project a year early for the current participants in those 9 states. And the way this is going to work is that calendar year 2022 will be what is called a performance year. They will use the data from the performance year, and then do their calculations and adjust payments beginning in calendar year 2024. So again, a full calendar year's worth of performance data. They'll do their calculations in early 2023 and then publish them in summer, the updates in summer 2023 to start taking effect January 1, 2024. One of the things that it also did, I just want to flag this as well, is it amended the Home Health Quality Reporting Program. This is important because the Home Health Quality Reporting Program is how you get value-based purchasing. Remember, value-based looks at not just cost, but also wants to make sure that quality has not been negatively affected. So they need the data to do that. And if you fail to report under the Home Health Quality Reporting Program, there will be a 2% reduction in payments starting next year. Okay, next slide, please. So let me talk a little bit about the home health value-based purchasing demonstration. It's currently in 9 states, and as Michael said, it does not include Texas. There are currently close to 2,000 participating home health agencies. It was effective back in 2016, and they recently published the annual report. They published it just last month, analyzing sort of what has occurred. So from the 3 calendar years of data, there were not quite $605 million in savings. What they have noticed is that there were decreased hospitalizations and SNF usage, but increased outpatient emergency room and observation stays. Under the project, the payments for a home health agency may be adjusted up or down by up to 7%, depending on what the total performance score is. And again, there's so much information that we need to get out today. I'm not going to go into this into detail, but to calculate your total performance score, you use OASIS data, and there's complicated models. If anybody wants to know how you calculate a TPS, please let me know. I'll get that to you. Next slide, please. So again, the most recent data is the performance year of 4, which is 2019. And as I said, they just published this. So the TPS scores, which is again, is essentially your quality scores, increased by 8 percentage points in the demonstration states compared to the non-demo project states. Again, there is mixed findings on whether or not there was cost savings. The previous slide showed that there was a decrease in the number of them, but they're not clear if there was actually a cost because, you know, the unplanned hospitalizations might now be for more expensive or longer stays. Again, there were modest gains in quality of care. The good thing here is that we had greater improvements in functional outcomes for patients in the demo states versus the non-demonstration states. They found that there was no change in the CAPS measures of the patient experience, which is really good because one of the concerns is also that patients perceive they are getting less care, and that's not something what we have. Changes to the HHA operations in the demo states really focused a lot on accurate OASIS documentation at the start of the effort, at the start of the episode, and making sure that other quality improvement efforts are really not just underway, but also optimizing those. So your OASIS documentation is really, really going to become key, probably even more so. I know everybody says OASIS documentation is key, and I know there's a lot of emphasis placed on it, but this is how you start with the calculation of the total performance score. So I cannot emphasize enough that you need to make sure that your OASIS documentation is really solid for these projects. Next slide, please. I'm not going to go into this in a whole lot of detail, but these are the updated TPS measurements for 2021. I assume that these will be the same ones that they will be using when they go into a performance year next year for 2022, but obviously that's always something to be seen. So you can look through these in your own leisure and see where the data comes from and what the performance measures are going to be used to calculate a TPS measurement. Next slide, please. So this is, again, just some resources. There is too much to go into in great detail, but we have here the resources for CMS's website for home health value-based purchasing, a link to the final rule for calendar year 2021, which we've only got, what, 5.5, not quite 5, well, not quite 6 months left in the year, and then the proposed rule for calendar year 2022, which was just published, oops, I just lost my mouse, was just published about a week ago or week and a half ago. Next slide, please. Michael, this is you.
Glad to talk about it. Thanks, Heidi. We're going to now talk a little bit about the comprehensive joint review, joint replacement program that CMS implemented going back to April of 2016. We're first going to talk a little bit about what the program's about. The major payments initially affect hospitals, but then we're going to get into, you have to understand the basics of the program to understand where home health fits in, and we'll talk about that right after we finish talking about the basics. As I mentioned earlier, CJR was the first mandatory alternative payment system, and it was implemented in April of 2016, and initially it was intended to run for a 5-year period through calendar year 2020, and it covers lower extremity joint replacement, predominantly hips and knees, also referred to as LEJR. It also, however, covers ankles under certain circumstances. It initially was mandatory for approximately 800 hospitals and 67 MSAs. And what it does is place the anchor hospital, which is where the replacement takes place, at risk not only for the inpatient stay, but for almost all care and services provided to the patient during the next 90 days after discharge. In November of 2017, the Trump administration published a rule that continued the mandatory participation in the program for hospitals in all of the MSAs during the first 2 years, 2016 and 70, but made participation voluntary for the final 3 years, 2018, 2019, and 2020, in 33 of the 67 MSAs, and also voluntary for rural hospitals and hospitals with low volume procedures, even those in the 34 MSAs that were left. For 34 of the 67 MSAs, including MSAs in Texas that were included in the initial cohort, the program remained mandatory for all 5 years. During COVID, CMS published 2 interim final rules that for CJR extended the program for the final year through September 30th, 2021, and made several changes to compensate for the impact of COVID. In April of this year, CMS published a new final rule that actually extended the program for an additional 3 years through December 2024 for those hospitals in the 34 MSAs for which the program was mandatory. Everyone else was excluded. All the voluntary hospitals were excluded from the last 3 years. So if I'm a home health agency, especially one serving Texas, why is this of interest to me? And the reason is that hospitals have the ability to share savings and risk of repayment with other downstream providers, such as home health agencies, and they're referred to as collaborators. Hunter, next slide, please. As I mentioned before, CJR initially covered approximately 800 hospitals in 67 MSAs for the first 2 years. And for the final 3 years, it covered approximately 465 hospitals as a result of the voluntary nature of the program for some of those hospitals. And after September this year, only those hospitals where participation was mandatory will be covered. Certain Texas hospitals are part of the mandatory coverage. Next slide, Hunter. For the first 5 performance years, CJR covers all cases that fall within MSDRG 469 and 470, which cover major joint replacements or reattachments of a lower extremity, as I mentioned before, predominantly but not exclusively hips and knees. And they're distinguished by whether there are major complications or comorbidities, and whether the DRG covers a hip fracture or does not cover a hip fracture. They begin with the date of hospitalization, continue for virtually all care through 90 days after discharge, and as I mentioned, include virtually all Medicare Part A and Part B services, except certain services unrelated to the episode. Since October 1 of 2020, they also cover MSDRGs 520, 521 and 522. And these are new DRGs that we use to classify the procedures where they had hip fractures that previously were covered by the other 2 DRGs. They also now cover these procedures starting in October 1 of 2021 that are performed as outpatient surgeries as well. Can we go to the next slide, Hunter? And that wasn't true for the first 5 years of the program. This particular slide, which is taken from an earlier CMS presentation on the topic, lists services that were initially included and those that were excluded, and the specific services are now listed in the final rule and on the CMS website. You should note that most post-acute services, including home health agency, hospice, and SNF services, are under covered services that are covered. The costs are covered during the 90-day episode. Next slide. Skip the next slide if you would, Hunter, and go to the next one. So how does this work in operation? All providers within the system are reimbursed initially at their payment rates under the normal fee-for-service basis. However, CMS has set what it now refers to as a quality-adjusted target price for each hospital in 4 areas: MSDRG 469 with hip fracture, MSDRG 469 without hip fracture, MSDRG 470 with hip fracture, and MSDRG 470 without hip fracture. And since October of 2020, it also includes MSDRGs 521 and 522, which classify hip fractures. At the end of each performance year, CMS is going to compare the payments that it made for each hospital's covered episodes against the composite quality adjusted target price. If the Medicare payments for the hospital initiated episodes in the performance year were less than the target price, and if the hospital meets certain quality metrics, then the hospital gets an additional payment that is referred to as a reconciliation payment. If also, because this is a 2-sided risk program for all but the first year, if the composite episode payments for the hospital's patients in the performance year exceeded the target price, then the hospital owes a repayment amount to the government. And to emphasize, meeting certain quality metrics will play a significant role in the process. To provide even greater incentive for the last 3 program years, beginning in October, hospitals that receive a good or excellent quality score will receive an extra bonus payment. Next slide, if you would, Hunter. The target price for each of these 4 areas was initially based on a blended rate of historical Medicare payments for episodes initiated by the hospital, specifically in regional average. However, since performance year 4, 2019, the target price is now set based on average regional historical episode payments. Next slide, if you could, Hunter. And I apologize for speeding through these, but we've got a lot of information. These are the thresholds to exclude other outlier episodes. I'm sorry. There are thresholds to exclude outlier episodes in setting the target price. And because of the lag time between the data that are used to establish the target prices, the prices get updated periodically to reflect increases in payment rates. The program then applies what it refers to as a discount factor to the historical payment calculation to set the target price. And for the remaining 4 years, of the program, also the hospitals was responsible to repay certain amounts to the Medicare program if the actual Medicare payments for its CJR episodes exceeded the target prices. The discount rate that's now applied is set at 3%. And so absent any adjustments to its target price, the target price is going to be 97% of the regional historical payments. And the discount factor is how the government ensures that the program will lower Medicare spending on these cases. Next slide, if we can, Hunter. The hospital can obtain a reduction in this discount percentage by meeting or improving its score in 2 quality metrics listed on the slide. Basically, complications of hip and knee arthroplasty surgery and a hospital patient satisfaction survey known as HCAHPS. In order to be eligible for any reconciliation payment, the hospital's got to obtain a quality score that is rated as acceptable, good, or excellent. And for performance years beginning in this October, the hospital can achieve an increased incentive factor to lower the discount rate by achieving a rating of good or excellent quality. So again, meeting these quality metrics is absolutely critical. Next slide, if you would, Hunter. Now this chart on slide 77 essentially comes from HHS and shows how these quality metrics affect the discount factor and therefore payment. And while it isn't shown here, the impact, as I mentioned, can be even greater in the coming years for scores of good or excellent quality. However, as you can see from the chart, how a strong quality score can take the discount percentage down, which in turn increases the potential for receiving and the amount of the reconciliation payments or payments that you owe back to the government. Next slide, Hunter, if you would. And finally, CMS limits the amount of loss or repayment on gains or reconciliation payments by a percentage of its Medicare payments during the performance year. Currently, it's capped at 20%. So in essence, hospitals are responsible for keeping total Medicare payments per episode for the affected MSDRGs below historical costs, reduced by a discount percentage. And if they do that and meet certain quality metrics, they're eligible for a reconciliation payment. And if they exceed that level, they're going to need to repay the Medicare program. And the metric against which they will be compared depends upon their ability to achieve good quality scores. So they're going to be looking, and they have been looking, to downstream collaborators such as home health agencies to help them achieve both of these goals. And as we'll show you later, one of the ways that they've been successful is actually reducing SNF skilled nursing facility stays and or the length of those stays. Hunter, can we go to the next slide if we could? I'll skip this slide if you would. Now, how do home health agencies fit in? This slide shows a list of the types of providers and practitioners who are eligible to be what we call collaborators. Under the program, note that therapists in private practices, corps, group practices, non-physician practitioners and therapists are included, as well as home health agencies and skilled nursing facilities. Hospices are not included as potential collaborators, and hospitals are permitted within certain limits to offer collaborators an opportunity to share in any reconciliation payments based on their performance in helping the hospital meet these goals, or to achieve internal cost savings that they realize through activities related to CJR, and this is referred to as gain sharing, and to enter into risk sharing arrangements in which the collaborators would share in any repayments to the government. Under the program, neither is required of hospitals, but they are permitted to do so. So there are both potential upside and downside risks for home health agencies. Next slide, if you would, Hunter. There are a number of requirements for these sharing arrangements. Many of these are listed on slides 26, 27, and 28, and you can read them at your leisure. But among these, I'm just going to mention a few of them. Most importantly, the collaborator must enter into a written sharing agreement with the hospital. That's an important agreement and that you're going to want to work with your lawyers on. Also, only collaborators other than ACOs or practice groups that furnish billable services during a CJR in a year in which the savings or losses are occurred are eligible. In other words, you've got to have furnished a billable service during that period if you want to be a collaborator. And the reason is concern over kickbacks. Also, hospitals have to have a compliance program that includes oversight of the sharing arrangements and compliance with the requirements of the CJR model, and the collaborators also must have or be covered by one that has these components. So while we've always preached the importance of home health agency and hospice clients having a compliance program for a number of reasons, for home health agencies, if you want to participate as a collaborator, you've got to be prepared to revise your compliance plans to accommodate these. Next slide, if you would, Hunter. Also, gain sharing payments have to be derived only from reconciliation payments or internal cost savings. They can only be distributed once during a calendar year, and there can be no gain sharing payments to a collaborator that is subject to an action for non-compliance or non-compliance with fraud and abuse rules. And they can't restrict the ability of the collaborator from making decisions in the best interests of the patients. Next slide, if you could. These are worth, by the way, you're reviewing in greater greater detail. The methodology for determining gain sharing payments has to be based, at least in part, on a criteria related to quality care provided to CJR beneficiaries. The agreement, which, as I say, is really important, has to set forth the specific methodologies, and the methodologies have to be based at least partly on quality of care and can't obviously account for the value or volume of care. Again, they're complex agreements that need to be gone over with counsel. Next slide, please, Hunter. The hospitals are also permitted to provide certain in-kind patient incentives to encourage patient engagement, and they've got to be related to medical care of the episode, related to adherence to drug regimens, adherence to a care plan, reduction of readmissions and complications, and management of chronic diseases that can be affected by the procedures. And the slide lists other limitations, but OIG and CMS also issued a joint document waiving the application of the anti-kickback and Stark rules under certain circumstances to conform to these regulations. And while the waivers are still in effect for CJR, as we've mentioned, OIG and CMS also published additional safe harbors that relate to these. So next slide, please, if you could. There are certain waivers that CMS and OIG have applied, and they involve both visits, incident to visits, even when the patient isn't homebound, waiver of certain telehealth visits, and again, you can read from the slides. Next slide, Hunter, if you would. Also, they waived the 3-day hospital rule for performance years 2 through 5, and now for the last 3 years for SNFs that have at least a 3-star rating. There are also certain beneficiary protections. Hospitals can't force beneficiaries to go to any downstream provider, but they can tell the beneficiaries of a list of their preferred providers, and you want to be on those lists. Next slide, if you would, Hunter. The next 3 slides, we're going to skip. Skip the next slide as well, Hunter, and the next slide, and the next slide, if you would, and go to the next slide. We've skipped those 4 slides because we've already incorporated them. They discuss the interim final rule and the new final rule. And again, you can read them, but we've incorporated those into the discussion. There's some practical guidance here that's important on the next 2 slides. I'm going to let you go through these, but obviously you want to know who the hospitals are in your service area that are covered. You're going to want to need to understand your costs and caregiving abilities. Do you have the capability to provide the data that the hospital is going to demand? Next slide, if you would, Hunter. What's it going to cost to enhance your data? You're going to need to have an effective compliance program. How important, you're going to want to know how important is the hospital relationship to your success overall. And Hunter, if you'll go to the next slide. Back up one, excuse me. Back up one, if you would, Hunter. My apologies. As a practical matter, hospitals are likely to be looking to limit the time that patients spend in skilled nursing facilities and nursing facilities for these services, and look to you folks to provide post-discharge care, and the results from the CMS evaluation of performance years 1, 2, and 1 through 3 bear this out. Next slide now, if you will, Hunter. However, if you want to play in this arena, you're going to need to be able to pull together data that demonstrate that you can care for these patients in a cost-effective and quality manner, and holding down costs not only to the HHA, but overall. You want all the players sitting at the table. You're going to want to go through claims data. The hospital will have these. And to avoid loopers, you're going to want to demonstrate how additional care cuts down costs later on recidivism. And since the hospital is going to be graded on its result, you may find that you got 2 components, one for your performance and one for the group overall. And finally, this slide and the next slide. And given the increased importance of the discount factor on quality, you're going to want to make sure that you focus heavily on your star rating. These next 2 slides simply provide CMS evaluations on performance years 1 and 2, and what they basically show is that many of the hospitals got a reconciliation payment. A large percentage got reconciliation payments in 1 of the 3 years, and also that CMS has saved money in the 3rd year, 2% of costs. So you're likely to see this continuing as time goes on. And because of the results, you're also likely to see, we think in the future, can you go to the next slide, Hunter? Yeah, as you can see, they showed a net savings of 2%, and they distributed almost 91 million in reconciliation payments. So this has turned out to be a win-win, and you can expect to see more disease-specific methodologies in the future. And now, Heidi, I'm going to hand it over to you to talk about shared savings. And my apologies, this has taken a little longer than we anticipated because there's so much material, but we're going to move through it.
Thank you, Michael. Hunter, if you could advance 2 slides, please. Okay, so I'm going to briefly talk about accountable care organizations. These were some of the first value-based payment approaches under the MSSP, the Medicare Shared Savings Program. Those of you old enough to remember gain sharing, it's a little bit like that, but not, and it's a little bit different. But the accountable care organizations, this model has turned out to be a foundational element for all of these other value-based care payment programs. One of the things to note right now is that we have 28% of Medicare fee-for-service beneficiaries in an ACO. So there's a lot of data that is being accumulated on this. And as an aside, data. If there's one thing you take away from this presentation, is that all of these value-based programs really will rely on data, and it puts a premium on the ability of your home health agency to gather, quality control the data, and then share it with other participants. Next slide, please. I'm not going to talk a whole lot about what an ACO is. I presume most of you are familiar with them and who the players are. These slides are in here for your reference. But one of the key things to notice is, again, there are minimum numbers of beneficiaries, 5,000 beneficiaries under each ACO, which is, again, how they get at statistically valid data. Next slide. And then one more after that. So the currently active ACO programs, there have been a number of them over the years. There was the Pioneer, there was a couple of others, but anyway, right now we still have the Shared Savings Program. There's 55 ACOs in Texas. The next generation model is winding down. There are 3 next generation ACOs in Texas, and these are not the same things as the MSSP. This, as I said, is winding down and will end December 31st. And then we have the comprehensive end-stage renal disease care model. We have 2 of those in Texas, 1 in Houston and 1 in Dallas. Next slide, please. This is a little bit of summary data. Again, going to let you kind of look at this on your own. Next slide is a map. Again, you can kind of go through this on your own. Next slide, please. They made some changes in 2019 to the MSSP ACOs. They called it Pathways to Success. And what this did was to transition ACOs much more quickly into downside risk models. Downside risk means you have to take a share of any losses. One-sided or upside risk is where you share in the savings. But one of the key things has been, again, with value-based to drive down costs while making sure quality doesn't suffer. So now they're trying to transition people into downside risk much more quickly. There's a number of submodels. I'm not going to go into them in detail. Again, there's a resource there for you to take a look at. Next slide, please. Actually, I'm going to skip this one and the next one in the interests of time. Again, you can read at these on your own leisure. One more, please. So again, in an ACO model, providers are still getting the fee for service payment, but then on the back end, on the other side, when an episode is completed, they go and reconcile the fee-for-service payment to a benchmark that has established, and you either get a bonus or you have to pay back money depending on whether or not you have met your goals and the benchmarks. Next slide, please. One of the key issues here in this risk versus reward is patient stickiness. Patients join or are assigned to an ACO, but they don't always stick with it. And then, how do you calculate a quality score and then a corresponding payment if the patient doesn't stay in the ACO for a very long time? So they currently have 2 basic track models, a one-sided, which is sharing in savings only or a reward, and a 2-sided model with 3 variations of different risk levels and reward levels. And again, those are not only positive payments, but also paybacks to Medicare if you don't meet certain targets. There is also an enhanced model. It's basically your 2-sided model, but higher amounts of risk and reward. Next slide. So what they've done is they have tweaked it a little bit for the upcoming years. And again, you now have what is called a basic glide path, where you have to meet quality scores before you can participate in the savings. And you have to you have to meet the minimum savings rate in order to get any savings. So again, these vary a little bit depending on which particular category you're in, but you have to save a certain amount of money, and then you can share in up to 50% of the savings depending on which level in. And again, over time, you participating entities incrementally assume more risk and also get more reward from the savings. Next slide, please. As said, the enhanced track is basically both savings and loss, and it's very similar to the other ones. You have to have a minimum savings of 2%, but then you can get in up to 75% of the savings. On the losses, you're going to share in at least 40% of the losses and up to 75% of the losses. And again, eventually these will trickle down to all participants in the ACO. But you can see why it is so important to have the quality measures and the quality scores in place to undergird this. Next slide, please. I'm not going to go into the details of the quality measures. I will say that most of them, again, are pay for performance. In other words, you have to have performance to certain standards, although a couple of the measures are simply pay for reporting. And again, what happens is they have established benchmarks for these quality measures based on previous year's data, and then you're held to those benchmarks. Next slide, please. The data is collected versus the CAP survey, claims, the EHR incentive program, and there is also a web interface for group practices to report the data. Next slide, please. And actually, these next 3 slides are the quality measures for ACOs for 2020 and 2021 performance year, which started October 1st of 2020 and will run through September 30th. I'm not going to go into them in detail. Again, you can look at these at your leisure. So can we skip to slide 41, please? Okay, so one of the keys here for an ACO is systems integration. Again, the hospitals will be gathering, or the conveners of the ACO will be gathering this data. So your EHR must be able to track the relevant data, and you have to be able to export the data to the ACO. Some of this can go via web interface. The data management is really a key issue here. I have actually seen an ACO model where, for a variety of reasons, the ACO didn't rely on the collaborator agencies exporting data. They actually set it up so that they could reach into your EHR and pull out and extract the relevant data. That, of course, has system security issues and HIPAA issues, so that's something that you need to think about. But again, all of this data is then munched and crunched through data analytics to come up with your quality scores, which are reported and then serve as the basis for seeing how you either have savings or have, if there are losses in the program. Next slide, please. So again, where do home health agencies and hospices come in? Well, the big thing is care coordination. This is really key. There's key information to have about the transfer from an acute care setting to a post-acute care setting and who has accountability for what. This is a key issue that we've seen over and over between home health agencies and ACOs. And the transition also, how do you continue healthcare between the settings? A couple of key things here are medication reconciliation, which actually happens to be one of the key things that they look at, and patient education. The patients are often, if they're coming out of an acute care setting into a home health, they may be a little bit fuzzy on this, and there's a lot of patient education that needs to be done with this as well. Next slide. So, disease management, again, goal setting, planning, patient training, and then active and continual follow-up. One of the key things that home health agencies in particular do is they prevent rehospitalization. And again, that's what we are looking at with much of the ACO models. We want to make sure there are no re-hospitalizations because hospitalizations are expensive. And then, of course, data collection. I've mentioned this before, but OASIS, falls, immunizations, home health compare, patient satisfaction scores through the CAHPS survey are very, very important. If you are not familiar with gathering data and working with data and analysis, I strongly recommend you have somebody on your staff, or you contract with somebody who can do this for you. Next slide, please. If you have not joined an ACO, some considerations you need to understand what the protocols are for care delivery, how you are going to have clinical integration. I've already said this, your ability to collect the data and then provide it, what the use of technology is going to be. You know, I have seen an ACO where, because of the data collection issues, they've mandated use of particular EHRs. Is that something you're going to need? If you're new to ACOs, it is not cheap to start joining an ACO. So who is going to pay for all of your startup costs? And then you want to know, if the ACO has savings, how is that going to be shared? You want to make sure that you get your fair share of any savings as well. Next slide, please. Michael, I think this is yours.
Yeah, and Heidi, thank you. And our apologies. This is going to extend a bit over the hour, although we'll try and move it. I'll try and move as quickly as I can through what is the granddaddy of the existing models, and one that I think you're going to see more of and more of in the future, and that is global and professional direct contracting. I do want to very quickly reiterate, not just for Heidi's points, not just on for the shared savings and ACO programs, but for all of these programs, which is care coordination, care coordination, care coordination, data, data, data. They want to minimize institutional care to the extent possible while getting the proper outcomes. And if you want to, as home health agencies, you're going to want to minimize LUPAs, and that means showing values on value on things like recidivism, and lowering costs by having more greater home health. This last model is the global and professional direct contracting model. It's an outgrowth of the Medicare Medicare shared savings model and the next generation ACO models that Heidi discussed. And it involves entities that are willing to take substantial risk. This is where the horse is going as we get further into the value process. And there are two basic models, what is referred to as the professional model and the global model. The professional model involves taking less risk than the global model. Global model is actually a model where the contracting entity, known as a direct contracting entity, or DCE, takes 100% of the risk for patients. In terms of the DCE, it's somewhat similar to an ACO in that it is a separate legal entity that can be comprised of providers such as an ACO. The professional model takes a risk level of 50% of the shared savings, or in even lower or losses subject to risk corridors. And there's also an option of taking this risk only for primary care services, which is equal to about 7% of your capitated payments. The program runs for 5 years. COVID delayed its implementation, but the first performance year started in April of 2021 and runs through December of 2021, with the final year being calendar 2026. There was also an option for direct contracting entities, DCEs, that had been accepted for the first cohort to delay implementation until program year beginning in calendar 2022, and that's as a result of COVID. There will be no new entities permitted to join the program, at least for 2022. However, it's important to understand this model, since we're likely to see more similar models in the coming years, and including some in the private insurance market. Also, the Innovation Center is preparing to get clearance for a somewhat similar model that is regional in nature and will be at a much larger scale, known as the geographic direct contracting model. And several of these entities are actually participating in parts of Texas. Can we go to the next slide, Hunter? These are the three types of DCEs. The first one is referred to as a standard DCE, which is an entity that has substantial risk experience serving Medicare fee-for-service beneficiaries and undertaking risk. Again, such as an entity that's participated in the Next Gen ACO program. And this is really, in some respects, a graduate program for those folks. This would be a natural next, and it's a natural next move on the risk spectrum. These entities would need to have at least 5,000 beneficiaries for all their performance years. In order to attract new participants, there's also what is referred to as a new entrant DCE, which is less experienced in serving, has providers that are less experienced in serving fee-for-service beneficiaries and taking risk. And this type of DCE needs to incorporate at least 50% of participating providers, which are basically primary care physician practices and other upstream entities that do not have experience taking risk with fee-for-service beneficiaries. These DCEs can start with fewer beneficiaries and build up to at least 5,000 beneficiaries over time. And then the third type of DCE is what is referred to as a high needs population DCE and takes risk for its fee-for-service beneficiaries with complex needs. The beneficiaries that are eligible for this type of DCE are spelled out in the model description, but basically would operate this would operate similar to a PACE program, or the program for all inclusive services for the elderly. And these DCEs have a requirement for fewer beneficiaries, starting in the first year at only 250 beneficiaries, but you can only be a DCE, one type of a DCE. You can't split up in any way. This slide has a bit of a misprint. As I stated up front, the program is not accepting new applicants for 2021 and the 2022 years, but there is no decision on applications for later years at this time. Also, as I've mentioned, the Innovation Center is looking at a regional model for the future where the DCEs would be required to cover a larger geographic area and is currently imagined serve at least 75,000 patients. Can we go to the next slide, Hunter? We've discussed the information on this slide, which simply shows two voluntary risk options: the professional level, which accepts a smaller portion of risk, but still substantial, and the global option where the DCE takes 100% of the risk. Next slide, Hunter. And we're almost to the end, by the way. While not on this slide, in terms of participation from the provider side, you have what are referred to as participant providers and preferred providers. Participating providers are listed in the FAQs, which are on the CMS website, linked in the CMS website, as generally ACOs and like organizations, networks of individual physician practices, such as an IPA, hospital systems, integrated delivery systems, hospital medical practice partnerships, and Medicaid managed care and other MCOs and payers. Although the FAQs also list entities such as skilled nursing facilities and a catch-all called others. And preferred providers are provider entities that are not used for attributing beneficiaries to the organization. The general downstream providers, such as home health agencies that participate, will likely do so as participating providers unless they're part of one of the larger groups that I mentioned earlier. In terms of the types of entities that cannot serve as participating or preferred providers, there are really only a few: DME suppliers, ambulance suppliers, drug and device manufacturers, and suppliers and providers that have been excluded from Medicare or Medicaid. And you see the same exclusion generally in the anti-kickback safe harbors that we previously mentioned. The slide also lists features of the model, and there's one mistake here, and that is participating providers have to be subject to the capitation mechanism and accept risk, whereas it's optional for preferred providers to be subject to this mechanism. There's substantial flexibility for negotiating deals with preferred downstream providers, and you can read the rest of these. The rest of these. Next slide, please, if we could, Hunter. This slide lists several of the model flexibilities, many but not all of which were seen in other models such as CJR and Medicare shared savings and ACO programs, the waiver of the 3-day skilled nursing facility rule, enhanced telehealth benefits that don't rely on have geographic or site of service limits, enhanced post-discharge home health benefits, enhanced care management home visit benefits. Now this one's kind of unique. There are additional home health benefits that don't require the waiver of home. There's a waiver of homebound requirements for certain of these. That's unique here. And then several others. Can we go to the next slide, please? This slide simply shows the quality measures that will be applied to the GPDC model. And you should note that readmissions are an important component and that there are only 5 of these. And again, home health agencies can play a significant role in this model. We also, as I mentioned, we also provided slides to the Medicare Advantage program, new special supplemental benefits, and to the BPCI program. But I want to thank all of you. Hunter, do we have any questions that we can answer for those folks who are, we're skipping the remainder of the slides, Hunter, but do we have any questions for any of the folks who have remained here? Hunter? Okay, I don't see any. But again, if anybody has any questions, please feel free to reach out to Heidi and me, Heidi or me on this. We're happy to talk with you, and the slides will be distributed, but let us know if you have trouble retrieving them. Hunter, do you have any, Heidi, do you have any closing remarks?
Data.
Hunter, anything to close?
Mr. Cook.
Anything?
Oh, no, yep, there we go. Sorry, my microphone wasn't working very well. I do have one question.
Sure.
Can hospitals who have not been participating in CJR join in, or is it closed to hospitals that are already doing it?
It's closed now because the only hospitals for the last 3 years that are permitted to be in there we're in our last year right now, and the only hospitals that continue are those that were mandatory and in the mandatory MSAs for the last 3 years of the program starting in October. So those that were voluntary can still continue for the last part of this year, but then you're just dealing with the mandatory participants starting in October of 2021. All
right, and that is the only question I have. Everyone, thank you so much for attending this webinar, and I hope you have a wonderful rest of your day. And to those asking, yes, there will the webinar will be available after today. That is correct. It will be available on our website. All right. Thank you so much, everyone. Have a wonderful day.
Bye-bye.
Thank you. Bye-bye.